Ovoid, as well as the Tandem and Ring. So we're going to get started here with the Tandem and Ovoid digitization, and we're gonna kick this off from the point at which we have already contours. So if I go ahead and make this a little bigger, and please feel free at any time, if anyone has any questions, please feel free to let me know. Stop. I'm happy to discuss, especially since I have Dan here as well, who's the real expert on all of this stuff. So if we just take a quick look through this scan, we start from the superior part of the patient. We're coming down through the patient. We can already see here in the middle of the screen, this is the tandem sitting inside the uterus. Off to the patient's left here, we have the sigmoid starting to be contoured, still moving down through the patient. Now we have in red the high-risk CTV, call that the HR-CTV. See how this, okay. And on the top here, we have the bladder. So we have sigmoid, high-risk CTV, bladder, and now the sigmoid turns into the rectum, and we have the rectum contoured here. And as we move further through the patient, now we're past the cervix, past the HR-CTV, and now we see still the tandem in the middle here, and now we see the two ovoids sitting right up against the cervical os, just below the HR-CTV. Keep going through the patient, we have bladder still, and rectum, and that's it. And then we're coming out of the patient here. Okay, so the first thing that I like to do, I'm just going to go through exactly the strategy that we talked about during the presentation a few weeks ago. So my strategy is this. We're going to look at the axial image, the top left image on the screen, and I'm just going to scroll through it, paying only attention to the tandem. So I'm not concerned about the ovoids at all at the moment. I'm looking just at the tandem. And I'm going to watch how that tandem behaves with respect to this central plane here that I have. So I set this plane up on my tandem. And then as I scroll through, I'm just going to zoom this up a little bit. As I scroll through the patient, I'm going to watch, and I see that tandem is coming off of that line just a little bit. See that? So it's perfectly in the middle of the line here, and then as we move up through the patient, it's coming off of that line. And the result of that can be seen here. We're sort of missing the top of the tandem. If you look at the bottom right image, we're definitely missing the top of the tandem. We don't see a clearly defined top of the tandem. So I'm just scrolling back and forth, getting a feel for what's happening. So I realize at this point, I'm going to have to rotate the tandem in order to get it in that plane. Again, the whole point of this is to make it easy for us to digitize the tandem. So I'm just rotating that a little bit counterclockwise until the tandem is coming in line with this plane. And we can see again on the bottom right, now we have quite a nice image of the tandem. It's not fading off. We're seeing a definitive end to the tandem. I'm going to scroll back through here, and the tandem is actually staying really nicely in that plane the whole way as I scroll up and down through the patient. Okay? So that puts us in a good spot. And in this one, luckily, it's also very, very straight here. So I would look now on the bottom left image, and I'm going to scroll through again. Again, just paying attention to the tandem, just watching how this tandem interacts with this line. And in this patient, we don't require any rotation. As I scroll through that image, the tandem is staying dead on the center of that line. If we did require rotation, I could do a rotation in this image, go back and check in the axial image. But at this stage, I'm happy that we are now in the bottom right image, looking at the perfect central part of the tandem. So I'm going to enlarge this, and then I'm going to go ahead and add a catheter that we can digitize. And then I'll just copy it because ultimately we're going to have a tandem and two ovoids. Then I'm going to go back in here. I'll call this our tandem. I'll say OK. And then depending on your treatment planning system, different ways of doing this. I'm also going to look at changing our window level. And at our institution, we know that if we use a window level of about 0 to 1,000, then when we see this here, we can start digitizing right at the top of at the top of the tandem there. So in our planning system, we're looking for that orange box just touching the edge of the tandem that's visible on the screen when we have this window level setting. You're going to need to make sure that for your institution, this is also true. You're going to need to check which window and level corresponds to the actual end of the tandem. It will be different depending on your CT imaging protocol, but this is what works for us, and we've tested that using film, and that's part of the commissioning process. That's right. So I'm going to go ahead and here we like to always digitize well past where we're going to add sources. And I'm just simply running along the middle of that hyperintense area because we know now from those other, looking at the other planes, the axial plane, the coronal plane, that we are right in the middle of the tandem. So we're never going to load past the flange, but we will digitize past the flange. And then I just want to go back and look at the other planes here. So now I'm going to scroll through the axial plane, the top left plane, and have a look. Everything looks good. We knew it was going to come out like that because that's how we set it up originally, and that's why we went through the process of setting it up on the axial plane, on the coronal plane, and then digitizing on the sagittal plane. So I'm going to look as well on this plane, bottom left plane, scrolling through, making sure that our digitization again runs right through the middle of that tandem the whole way. If it didn't, or if we weren't happy with it, we could then make some adjustments on either of these planes. But at the moment, I'm pretty happy with that. Okay, and since we have everything set up on the on the tandem view, everything is aligned to the tandem view, I'm going to go ahead and place our point A, which is what we're going to use for planning. So I'm going to bring this slice down so it's sitting right at about the flange at the top of the ovoids, right there, hitting the top of the ovoids. It's in line with the tandem, and I'm going to rotate the tandem, move this axis over, so that when I go 2 centimeters up from the flange, I'm still going to be in the tandem. I'm going to rotate that a little bit. And we already have one in here. I'm just going to delete that and recreate it so we're not cheating at all here. Okay, so now we have set our viewing plane intersection such that we're right at the flange and we're centered on the tandem, and 2 centimeters up from that, we are still in the tandem. Okay, and then this is going to be different depending on which treatment planning system you use, but what's easiest for us to do at this point is to right-click on the user origin, say set our user origin, and we're going to set it at the viewing plane intersection. So this is the intersection that we just set up. Now we want to set our DICOM user origin to that point. That's great. You can see this little green cross that shows up, and our DICOM origin is there now. The reason we do that is then it becomes very easy for us to put a grid on that is a 2 centimeter grid, and it's centered around that user origin. And then, as we discussed a couple of weeks ago, point A is defined as 2 centimeters up and 2 centimeters out. Again, this is a 2 centimeter grid. You can see that here. This is not a 1 centimeter grid. This is a 2 centimeter grid. So from that user origin point, we're going to go 2 centimeters up and 2 centimeters out, and we're going to go both to the right and to the left. In our treatment planning system, it is easiest for us to create a reference line. So point A in our treatment planning system is actually a reference line. And then we can go ahead 2 centimeters up, 2 centimeters out on the right side of the patient, 2 centimeters up, 2 centimeters out on the left side of the patient. And then this reference line becomes our point A. We'll see why we've done that in a little while. Okay, so we still have not digitized the ovoids. All we've done is digitize the tandem. We haven't even loaded the tandem, and we've digitized, and we've put in our point A. So to digitize the ovoids, I have a right ovoid and a left ovoid. And I'm just going to use exactly the same strategy. So again, I'm going to start on the axial image, and I'm going to scroll through the axial image looking for the ovoid. So here's the right ovoid, and here's the left ovoid. So I'm going to start with the right ovoid, and I'm going to go ahead and scroll through there. And again, I'm looking at how that ovoid interacts with our viewing plane, our vertical viewing plane here. And I can see as I'm scrolling back and forth through it, if I rotate clockwise this time, I can sort of bring it in line with that imaging plane. And then I'll center the imaging plane on that ovoid, scroll back and forth. I think I could use probably a little bit more of a clockwise rotation, center it again, and scrolling back and forth. Okay, so I'm happy with that at the important part of the ovoid, and then I'm going to come down to the bottom left image. I'm going to do the same thing. I'm going to scroll through it, and I'm going to see how that ovoid interacts with this vertical viewing plane line. So as I go through the ovoid, I'm really happy with that, and then as I come up here, I can see it's coming off of that line. So we're not going to load here, so it doesn't really matter, but it makes it a lot nicer if we make that adjustment such that everything is really well aligned and we have that really nice viewing plane. So now I'm going to scroll through here again after that adjustment, and I can see maybe coming off a little bit at the tip. So I'm going to go back up to the axial image, scroll through that. It actually looks pretty good on the axial image. Again, just looking at this right ovoid, I'm happy with that on the axial image. Okay, and then if we go down to our bottom right image, we can see we have this really nice, well-defined end of the right ovoid. Again, I'm going to make that large, select the right ovoid, and then I'll go ahead and digitize that ovoid. Again, we're not going to load past the bend, but we are going to digitize well past the bend. Okay, so that, and then we'll check in our bottom left image. We'll just scroll through and see if we're still in alignment with everything. Looks good. And then we'll look also on our top left image, axial image, and we'll see as well, is our digitization actually in the center of that ovoid. And if I wanted to, we could even go in here, maybe make a little bit of an adjustment here to get it just right in the middle of the ovoid. Okay. And then I'm going to go ahead and just do exactly the same thing with the left ovoid. So again, starting in the top left image, the axial image, I'm going to set my vertical viewing plane so it's somewhere close to the middle. Then I'm going to scroll through that. I'm going to see, oh, it looks like we're going to need a rotation, clockwise rotation this time, to bring that tandem in line with the vertical viewing plane. So that looks pretty good on the top left image. Now we're going to move to the bottom left image, and I'll scroll through that. I like it at the tip of the ovoid, but when we come up here, I have a feeling there's a bit of a rotation. So see here, it comes away from that vertical viewing line. So again, I'll just have a counterclockwise rotation, set that back to the center, maybe a little bit more. Put that viewing plane in the center, and then I'm going to go ahead and scroll through the bottom left image. See if it stays, if that vertical viewing plane stays in the middle of the ovoid for the whole time. And it does, it looks really nice there, right? We can see as we're scrolling through here, that left ovoid is staying right in the center of that vertical viewing plane. So I'm happy with that. Just as a check, I'll go back to the top left image, scroll through that. Again, the ovoid is staying right on the center of that vertical viewing plane. And if we have that set up for both of these vertical viewing planes, that means that over here on the bottom right, we have a really, really good image of the left tandem, and we can go ahead and digitize that. So I'll just do the same thing again. Okay, again, we're not going to load past the bend in the ovoid. Okay, so now we have all of our digitizations done. We've set up our point A. Now we can go ahead and load the catheters. So in our case, we go to Properties, and then we have our property window here. One thing we would also want to be very careful of, and this is what we talked about last week, is that we like to do a measurement of the length once we have the transfer guide tubes connected. So at our institution, at this point, we would actually go into the room, connect the transfer guide tubes, and then put a measurement wire all the way through each one of these catheters and measure the length. And from that, we would be able to determine what this length was. At our institution, with our transfer guide tubes and our setup, it should be always 132 centimeters for tandems and ovoids. And then whenever we go ahead and try and load tandems or ovoids or needles or anything at all, we always want to make sure that we are looking at the plane of the ovoid. So we're going to load the left ovoid. We want all of our planes set up so that we're actually looking at the left ovoid. If we tried to load the left ovoid when we were looking way over here, then we would get it wrong, right? We don't have any sort of relationship with the rectum here. It's a different relationship with the bladder, and it would be easy for us actually to load this incorrectly. Not so crucial for tandem and ovoids because it's kind of standard loading, but with any sort of needles or anything like that, it's just good practice to be in the viewing plane of the catheter that you're loading. Our system requires that we start at least 3 millimeters back from the tip of the digitization, and then we're going to add here 3 source positions. Maybe we can add 4 source positions. Okay, so we want to make sure again we're not loading any source positions beyond the bend in the ovoid, and that looks good. So then we'll go ahead and we'll load the right ovoid. Again, we want to make sure that we're roughly in the correct plane, looking at the right ovoid, and that'll make sure that we have a good idea of where all of our OARs are, organs at risk, as well as our HR-CTV. So again, we'll set the catheter length to 132, and again, we'll put in 4 dwell positions. Okay, so we're looking here, and that loads the ovoid, again, not past the band. Then we can go ahead and load the tandem. Again, we want to be in the plane. We can see here we're pretty close to being in the plane. I want to be able to see the tandem. Okay, there's the tandem. Again, we're not going to load past the flange, so we can go ahead, select the tandem, set the catheter length, and start at 0.3. And I'm not sure what this length is, but I'll just take a guess. 6.3. That's a lucky guess. Takes us right to the flange. Again, we don't want to be below the flange. And that's going right through our HR-CTV. So I'm pretty happy with that. So we'll say okay to that. We'll close this, save our work so we don't lose it. And now we don't need to have our strange window and level anymore. We can go back to a normal window and level. Okay, so we have all of our dwell positions, or we have our tandem and 2 ovoids digitized, and we've loaded them with dwell positions, and we also have a point A. Now we can go ahead and insert some dwell times. So if we look at our dwell control window, at the moment, we have no time in any of the dwell positions, but we do have all of our dwell positions set up for left ovoid, right ovoid, and tandem. So in our case, can you bring up the presentation from last week so I don't get this? Are we doing 10, 10, 15, 10, 10? I think it is 15,
well,
10,
depending on the length.
Okay, so
yes.
that's right. Depending on the length, the top third is going to be loaded at 15 seconds. Again, just speaking relatively here, 15 seconds. And the bottom 2/3 is going to be loaded at 10 seconds. And then the ovoids are going to be loaded at 15 seconds. And again, we had a graph or a table in the presentation from a few weeks ago that showed different standard loading patterns for different sizes, and I think also for different manufacturers. So this would be standard for this setup, is to have the top third of these set at 15 seconds. Again, this is just relative. It could be 1.5 and 1. It could be 30 and 20. It's just relative. So we'll put in the top third at 15 and the bottom 2/3 at 10 seconds. Again, just relative. And then in our ovoids, we're going to put 15 seconds for all of the 12. dwell times. And this actually comes from sort of historical treatments with radium where they call this 15, 10, 10, 15, 15. Okay, so now we have that setup, and that's going to be sort of our standard setup, again, depending on the configuration and depending on your manufacturer and depending on the size of the ovoids and all of those things. That's all in the table that we presented a couple of weeks ago. Okay, so I'm going to go ahead and close that. And you can see at the moment our dose distribution looks really strange, right? It's not really covering the HR-CTV. It's just right around the tandem and ovoids. And that's because essentially we haven't cared what the time is yet. We just wanted to get the relative times correct in all of those source positions that we just put in there. And then, really simply in our treatment planning system, I think it's fairly simple in most treatment planning systems, we're going to select that point A. So this is the point A that we defined earlier. Remember, it was 2 centimeters up and then 2 centimeters to the left, 2 centimeters to the right. And the reason we did that was so we could select it and then normalize our dose to that reference line. Okay, so this is going to normalize our 100% isodose to our point A. And this is going to be really the starting point for all of our planning moving forward. So at the moment, we have a standard plan. You can see our 100% isodose, 800 centigrade, is running exactly through point A. What kind of shape do we have here? We have a really, really nice pear-shaped distribution. We talked about that at length in the presentation. So definitely want to be looking for this pear-shaped distribution. The isodose line is coming up here. It's not bending way down here. So everything is looking pretty good. And it's actually also doing a pretty good job of covering the HR-CTV. So if I just scroll through this, it's doing a pretty good job of covering the HR-CTV, and it's also doing a fairly good job of avoiding all of the organs at risk. And I'm just going to scroll through each one of these slices and see. So I'm looking at how this 100% isodose line interacts with the bladder, whether it's covering the HR-CTV, whether we're getting too much dose in the rectum. Everything is looking pretty good here. So classically, this would be the plan that we would treat. If we were confident that we could properly visualize and contour what the HR-CTV was, and that we had a good delineation of organs at risk, then we could modify this plan. So I'm going to go ahead and call this plan HDR number 2, point A, and this will be our point A plan. And I'm going to copy that plan just so we always have it as a reference, and I'm going to call it maybe optimized plan, so OPT, okay? And then what we could do, if we were confident that we had really good visualization of our HR-CTV, and if we were confident in our ability to see the bladder and to see the rectum and to see the sigmoid, then we could go ahead and start to optimize it. And as I'm scrolling through this plan, just getting a feel for it, I know it's sometimes difficult to watch somebody else scroll through a plan. It's much easier if you scroll through it yourself. So I'll try as much and say going up through the patient to the tip of the uterus, going down through the patient, looking at how this is interacting with the HR-CTV. I'm seeing maybe we're missing some of the HR-CTV down here a little bit. If I keep scrolling down, again, we're missing some part of the HR-CTV. And then it looks like we're doing a better job. We're coming right close to the bladder here. So as a rough guide, we're kind of looking to have the 100% line stay out of our organs at risk. We'll look more at the doses to organs at risk in just a minute. Dan, I don't want to take too much of your time, so I'm going to wrap this up here in just a minute. But if I was going to optimize this plan, the way we do that in our treatment planning system is to use this thing called a dose shaper. And this is actually going to allow us to grab the isodose lines and move them in real time. We could do this as well just by changing the times, the dwell times. And I'm going to show you that as well before I start using this. If we go back to our dwell control window, just for interest, remember we set everything up at 15 and 10 seconds? But once we normalized it to point A, we actually end up with 73.7 seconds and 49.2 seconds. So that ratio, 1.5 to 1, it still holds, but the absolute time has been changed such that we get 100% dose at the point A. So then we could go in here and we could actually modify these times to try and get the dose a little bit further out here, or we can go ahead and try and grab this line and just bring it out a little bit. You see, as we bring it out down here, it's also creeping into the bladder. I think that's probably going to be our compromise for this plan. Maybe we can get some dose from the ovoids. So we'll try and pull some dose out from the right ovoid. Let's see if we can fill in some of that space that we missed. That's going to be hard for us to get, right? Because as we pull this out, our bladder dose is also going to increase because we're fairly far, you can see we're fairly far away from the ovoids here. There's not going to be a lot that we can do about this part of the HR-CTV. Feeling we're going to have to come off of the bladder here a little bit. You can see as I'm pulling those, these times are also changing. I don't want to do too much of this. It's very easy to get yourself into a loop where you're doing lots of optimization and having relatively little effect, or getting some really strange dwell times. And if I did get into a bad place here that I thought, oh, I don't like this plan, I can't get back to the original plan, then I could go ahead and go back to the plan that we saved that was our point A plan. So that's maybe a little bit hot, running a little bit hot. But why don't we take a look at our dose coverage? And I believe we also shared the spreadsheet for calculation. And so let's go ahead. In our treatment planning system, we have created a report that we can, thank you, that we can print. And here this gives us the D90 for the HR-CTV. Forgot to calculate the dose, final dose. And we have a D90 of 97.9, so that's really good. We're getting a lot of coverage. Our V100 may be a little bit low at 88.4. And then of interest for us in terms of the organs at risk, we want to look at the D2CC for the bladder, sigmoid, and rectum. And here we have a bladder D2CC of 6.5, which is maybe a little bit high. And then I go to sigmoid, 4.9, 5, and rectum of 4.8 gray. So without going into the spreadsheet, just to save some time, I would say this is probably a little bit high for the bladder dose. So I may close that and then scroll through the plan a little bit and see if we can find somewhere where we can bring this isodose line a little bit away from the bladder, because I feel like the bladder dose is a little bit high. That's where it's going to be high. So I'm just going to pull it back just a little bit. Again, we're in this compromise. There's always a compromise in these cases between HR-CTV coverage and organs at risk. May be able to bring, again, a little bit more from the ovoids. So I'm trying to pull dose from the ovoids to help with HR-CTV coverage down here. I think that's been quite successful, actually. Okay, so we can go ahead and calculate the dose again, and then we can look at our report. And really good coverage for D90, good coverage for V100, and D2CC bladder still quite hot, 6.44. So I'll go ahead, scroll through that again, try and see where that's happening here. I'm going to reduce that. And we would know if it was too hot using this spreadsheet that we have for calculating our EQD2 values, which I'm not doing at the moment, but just trying to get it down to something that's a little more reasonable. Okay, now we have it down to 5.7. And that's the battle. We could go back and forth trying to optimize that a little bit, trying to improve coverage, trying to reduce doses to the organs at risk. Having said all of that and having gone through all of that optimization, we could also just have treated our point A plan. So if we didn't have a huge amount of confidence in our ability to visualize the HR-CTV, then we would just go ahead and treat this plan. This is a perfectly acceptable plan. 5 years ago, 8 years ago, everybody was treating with this plan to point A with very little optimization at all. So this is a perfectly acceptable plan, and it's definitely always our starting point, and sometimes it's also where we come back to if our optimized plan doesn't really work out very well. Okay, does anyone have any questions before we transition to Tandem and Ring?
I saw that somebody did post one question asking which hospitals have a BABIG machine. So if there's anybody out there who's using a BABIG, if you could please respond in the chat, that would be great. Thank you.
This is Michael. I have a quick question, Derek and Dan. Do you use the plan evaluation tool when you look at plan A versus the optimized plan?
Yeah, so I think the question is, do we look at what the dose statistics are for the point A plan and the optimized plan?
Specifically, the tool on your, you're currently in the Brachy.
Oh, the plan evaluation tool.
The plan evaluation module in Brachyvision.
Get there.
And while that's loading, the other question I had was, in your report, unless you edit the template for the report and you program your D.1 cc and D2 cc organ at risk, those statistics into that, you would not see it, right? Do you want to, with those folks that have Brachyvision, it would be helpful if they don't know how to edit the report template, that maybe you provide some step-by-step instructions what to put into the template, where you find it on Brachyvision, so that, because you need those statistics readily from the planning system, and that's the best way to get it.
Yeah, this is a great point. You do have to spend some time setting up those reports. I think what Dan and I could do is to share with the group the templates that we use. So if groups are using ARIA Eclipse to do this planning, then they could just go ahead and use those templates as well. What do you think about that, Dan?
Yeah, that's a great idea. I can also send showing the where you do make those edits in that file and where it's located, kind of a pictorial guide, so that I would be happy to do that as well.
I think the Brachyvision manual readily talks about it. If one could even point out the pages in that, it's pretty straightforward. But someone else that has not edited the template files or created one, uses the report function, and it simply doesn't show up because it hasn't been added.
That's a great point.
Yeah, that's a really great point. Another thing you can do if you don't have the time or ability to set up, or your treatment planning system doesn't allow you, is to look at the dose volume histograms. So you can show the dose volume histograms here, and then you can actually pull statistics from that as well. It shows all the dose statistics down here for all of your organs at risk, as well as your HR-CTV. So it shows the coverage, minimum dose, maximum dose, dose to 2 cc's. So all of that information can be made to be displayed here as well.
Sorry, may I ask you a question?
Of course.
Hello, everyone. May I ask you a question?
Yes, please. Go ahead.
Thank you very much. Actually, for me, this is the first time that I look at the Tandem and Ovoid plan. I want, because I have a poor internet connection here, maybe I missed some part of your presentation, but I want to ask you that there is, as I see as I see, there is 3 plans: SDR1 and SDR optimized and SDR 0.2. By which one you treat the patient, the optimized one or 0.8 plan? Why you have 3 plans?
So I have the first plan here just because this is one of our test patients. So we've been using it for training purposes here. So this is just, we could just delete this plan. It would be perfectly acceptable to treat this plan, point A, because that is sort of a standard loading scheme, standard normalization. We would still want to look at all of the dose statistics for this plan. We would want to look at all of these numbers, but this is a perfectly acceptable plan. If you had a large degree of confidence in your ability to define the HR-CTV, then you could think about doing some of this optimization and creating a little bit more of a personalized treatment plan for the patient. So it's a little bit dependent on the amount of confidence that you have in your ability to visualize organs at risk.
So sorry.
No, go ahead.
You have a plan to treat it by the patient by the SDR PTA 4.8. So you treat it by the last one. You treat the patient by the last plan.
I think if we were pretty confident, if we had a lot of confidence in our HR-CTV, we would treat with this plan, the optimized plan.
Okay.
If we were not sure where the HR-CTV was, then we would treat with our point A plan.
Okay.
Does that make sense?
Yes, I understand. Thank you very much.
It has very much just to do with our ability, the amount of confidence we have in our ability to define the HR-CTV. And the reason I say that, actually, if we take off the dose distribution here, and we take off the catheters, and we just look through the CT scan. So let's take everything off. And now we're going to just be looking at the CT scan, no catheters, no anything. Yes. If I look through this, I think it is very difficult to define where the HR-CTV is. There's nothing in the Hounsfield units that allows us to very easily say, okay, well, here is the HR-CTV. So from my perspective, it's quite difficult to do that. We can use things maybe like calcifications or markers, or maybe this patient has an MR imaging from a different time. We can try and use things like that. But if we don't have access to that, and often here we don't have access to that, then the radiation oncologist who is drawing the HR-CTV is really just going off their clinical knowledge, their clinical exam of the patient, what they saw and what they felt when they were putting the Tandem and Ovoid in the patient. But from my perspective, I don't have a high degree of confidence here that this is exactly where our HR-CTV is. If we look at the HR-CTV on the CT, there's no sort of boundary definition in the same way there is. You can see where the bladder is. The bladder is very easy to see on the CT. The rectum is very easy to see on the CT, but there's nothing on the CT that tells me where this HR-CTV is. So if I didn't have a lot of confidence in that, I would be very careful in trying to do very much optimization at all.
Thank you.
All right, I'm gonna hand it over to Dr. Scanderbeg. He's going to walk us through a Tandem and Ring treatment. Okay. You might want to stop sharing for a minute.
That's what yeah. Okay. Sorry, I'm just going to stop sharing for just a sec while I switch over, make sure I don't show any patient information. Just take a second to pull up the next case.
And Dan and Derek, this is Ben Lee. I just wanted to say thank you so much for leading the session today.
Our pleasure. Glad we were able to do it, and we found a time that worked.
Mm-hmm. And Javier, thank you for your questions.
For you, Dr. Ben, I am really appreciated.
Mm-hmm. And if anyone else has any questions at any time, you can feel free to unmute yourself and speak. We would love to hear your voice.
Yeah, please take this opportunity as I'm pulling up this next case here.
Dr. Ben, I want to repeat my questions. Which hospital have the BABIG machines? I'm really interested to know because our hospital have planned to start the treat patient by using Tandem and Ovoid in the next 2-3 months.
Okay, I will look. I'm not sure if any of the centers are using BABIG machines in our cohort.
Okay.
Okay, I've got our case, so give me just a second here so I can share my screen and pull it up. I want to pull up a couple other things while I'm here. Where's your open list? Am I sharing again? You're sharing. Okay, perfect. Okay, I'm going to go through the Tandem and Ring a little bit quickly because Derek's already gone through this, and I think the majority of users are actually with Elekta or Nucleotron. So the specific button clicks are going to be different for our different systems. So let's start here. So I'm going to do a similar thing to what Derek did. So here I'm just going to kind of scroll through our images. We can see our Tandem and our Ring. So as I move here, I'm going to kind of look at our Tandem placement. So it looks like our Tandem is a little bit, so if I'm looking in our coronal view here, it looks like our Tandem is a little bit posterior, and here it's kind of on the right-hand side of the Ring. For this case. So ideally we would, have our Tandem placed kind of right in the center. We see a lot of packing here. We had some radio opaque packing as we're looking in the coronal view. And I believe in this case, what had happened was the packing kind of displaced the Tandem off to the side, and it was decided to keep with the implant rather than re-implanting and repacking. So we went with that, but you can see that the Tandem kind of skirts along the right-hand inner side of the Ring there. So again, as we rotate through our views, we can get to a view where we can see the majority of the applicator in all of our views. And so here we see the sagittal showing the extent of our Tandem. As Derek mentioned, a lot of times what we'll normally do is digitize past where we're going to load. I know for the Varian systems, if you are loaded past where you've digitized, you'll get an error when you try to transfer that plan to the afterloader. So that's something to be aware of, and I'll show you that in a minute. So we'll insert our new applicator. You can also insert solid applicators from your library, so that's possible as well. It depends on your process and if you have that available to you. So I'm going to label this our Tandem. Again, we'll have to enter our channel length, your step size from our planning document that was distributed. So for Gamma Med, we're using a 3 millimeter step size and 2.5 millimeter step size for Nucleotron. As Derek mentioned, our first source position, because of the way our afterloader works, it overshoots when it goes out. And so from that overshoot, we cannot treat to the very tip, and so we have to have about a 3 millimeter dead space allowance at the tip. And then I'll insert our last source position. And when I was talking about digitization length versus your loading length, that will come into this current geometrical length for Brachyvision. So, whoops. So I'm just going to do this quickly because your digitization will depend on how you've commissioned and the values that you've established in your workflow. So I'm just going to do this, as I said, very quickly to give you the idea, and Derek's already gone through this. So say we've digitized our applicator like that. If I come back, I'll see our geometrical length is 11.145 centimeters. So basically what that's telling me is I've digitized a length of a little over 11 centimeters. And so what happens is if I try to load my first and last, so I am loading a length greater than 11, it will display only to what you've digitized. So we actually have more dwell positions past where we've digitized that are not displayed, and that's because of this issue. So for Brachyvision, you really want to make sure that your last source position is shorter than your current geometrical length. Otherwise, when you export this to your afterloader, you will get an error. So as we said, as Derek mentioned before, we don't want to load past our flange or our ring or ovoids to have our protruding sources or flaming sources, as some call them. So here we have about a 5 centimeter active length, and then we would do the same for the ring. So I can move. If I adjust our geometry in our views here, I'll get cuts through our ring so that we can visualize here in our axial slice the entire ring. So we can insert our new applicator, depending on how you do that, whether it be direct digitization like this or with your applicator library. So again, in the interests of time, because it's almost been an hour, I'm just going to put our catheter kind of through here quickly. So I've digitized around, and as we look at the sagittal, what happens with our ring is our ring actually comes out up here. So again, we're not going to load anywhere up here, but we should digitize more than we have. So again, as Derek mentioned, go through and look at our axial, our coronal, our sagittal slices, make sure we're very happy with our digitization, and then we could add our dwell positions as well. So if I move this over, so see I've added dwell positions around our ring for Brachyvision. One of the tools we have So once we have our applicator here, we could figure out how many dwell positions we want on either side and kind of erase those. So we have however many we've decided. So here, the 34 millimeter nucleotron ring, we're loading 8 positions. The 30 millimeter nucleotron, 7 positions. The 30 millimeter gamma med, 6 positions either side. 26 millimeter ring for nucleotron, 6 either side, and the 26 millimeter ring, the gamma med, 5 positions either side. And this is all in your handout. And so again, we would go to our dwell control window, and then we could add our ratios here. So for an 8 centimeter tandem, a 6 and an 8 centimeter tandem, the distal third would be 15 seconds, the remaining 2/3, 10 seconds. For a 4 centimeter tandem, half and half. Half is loaded 15 seconds, proximal half 10 seconds, and then 2 centimeter tandem, load the entire tandem 15 seconds. So we would enter those here, and then we would scale that when we normalized to our point A. Adding point A is similar to what Derek showed. So while I'm here, I will just show a few other features. So if one of the reference points from the ICRU is the ICRU bladder point, and so we can add that as well as the ICRU rectal point. So the ICRU bladder point is, if you look at—
I don't have an answer for that.
Hello? Does it always do that? I guess Siri doesn't know what the ICRU bladder point is. So we're going to look at the posterior aspect of the Foley balloon. So in this case, most of the time our Foley balloon is loaded with contrast. So we can see that. Ours is actually reversed. So we typically will flush the bladder with some contrast prior to our scan so that we can visualize the bladder wall nicely in our scan, since we are doing volume optimized, and the bladder wall will matter for our D2CCs. But we can still see our Foley and our balloon in there and put in our ICRU bladder point. So it's the posterior aspect of the balloon, and then the ICRU rectal point will be 5 millimeters posterior to the posterior vaginal wall, kind of splitting the middle of the ovoids or at the bottom of the ring, and that's in the axial plane. I cannot pull up the spreadsheet template on this computer. I can't read it, but I can send out the information on that. Like Michael had pointed out, those are customizable templates in Brachyvision, so you can report dose statistics to whatever structures you've named. One nice thing about that is that you can have those reports, but you do have to keep all your structures named the same. Otherwise, the template won't be able to read it, because it's just, computer commands asking it to pull. So it is nice to have, maybe you set up a structure template so that you have HR-CTV, IR-CTV, bladder, rectum, sigmoid, with all the standard conventions for your naming, so that if you do have any customizable reports, those will always work. So since we're at about an hour, why don't we check in again and see, from this point here, we would just add our doses like Derek did, our 15, 10, 10 dwell weightings, and then normalize it to our point A, which he defined earlier, and then look at our dose statistics, and then kind of go back and forth between our dose statistics and our EQDT spreadsheet. Again, when you go back and forth, if you're doing any graphical optimization, or even if you're doing manual optimization, where you're manually entering your times for each of the dwell positions. It's really important to go back and forth between your isodose curves on your axial, sagittal, and coronal. Look at all of those, and then go back to your dwell control window and make sure that everything makes sense and that you're not very far from your point A original plan when you're starting to optimize to volumes. So, and again, that's especially important if you're using any types of graphical optimization. Are there any questions? Did I miss anything?
I think you got it all.
Okay, wonderful. We will make sure that we send out a video of this. I know some people struggled with unstable internet connections today, and so we'll have a smooth version that's edited for you guys to view. And feel free to contact us by email. Let us know if you want to get put in touch with any of the educators over any of the sessions that they've taught. They're very resourceful and very willing and happy to help.
And I think there was posted a recorded video that goes into more specifics on the ring, or that I had done previously, and then I think some other specifics with the ring and commissioning Adam was going to cover, or maybe he's already covered that.
So next week we will have Michael Tesoro sharing treatment planning for OnCentra, which I believe a lot of the centers have. It looks like that is scheduled for Tuesday, October 22nd at 8 a.m. Pacific time. And after his session, we heard that many centers are interested in contouring. And so we're going to have Dr. Anuja Jingran from MD Anderson join us, and she's going to do a special session on cervical cancer contouring, similar to how we did a session today on planning. So stay tuned for that, but we're happy to continue adding on more sessions to promote the best training at your guys' centers.
Okay. Very good. Thank you,
Great.
everybody.
Thank you so much. Thank you, everyone. Take care.
Thank you.